consider him as a father of diabetes in the kingdom. And he's going to speak about bariatric surgery for diabetic management on our local experience.
Assalamu alaikum, sabah al-khair. Mr. Chairman and colleagues, it's really a pleasure for me to be here. And I would like to thank the organizers for really launching such a meeting, because I think we need it. We need it for many reasons. One of them is that this could be one of the line that we could go through to try to do secondary prevention programs for diabetic patients. Those of you who doesn't know the relation between me and Dr. Abdullah Dahayan, I was his resident 35 years ago. And I still remember when he was trying to escape from the in-call medicine to go to the OR, because he was at that time interested in surgery. And sometimes he bribed me by buying me a sandwich, which is a broad bean sandwich. I was Bedouin. I never thought that you can put broad beans inside a bread to be a sandwich. But he is the one who showed me that invention, which was really great. So I would like to ask the delegates from Japan, ask Dr. Abdullah to take you to Filfila. I'm sure you will enjoy the sandwich there. Now let me look at the angle of bariatric surgery from a medical point of view. I'm very pleased that our colleague have just shown you the surgical point of view. I'm going to look into it from the medical point of view. This is a program which we have launched with our colleagues from surgery department in King Khalid 5 years ago, almost now. And this program is meant to assess the effect of different bariatric surgery on diabetic patients' management. It was submitted to approval, and we call it Saudi Bariatric. Our aim is to do as many as we can, although the first request is for the first 200 patients. I'm sure all of you knows about this. This is a Nature paper which was published in 2016. I like the statement that they have released in September 2015 that that surgery has to be one of the options for managing diabetic patients, especially type 2 diabetic patients. Although I would like to tell you that in our program we have also included type 1 diabetes, especially the obese type 1 diabetic. I'm sure also most of you know about this diabetes care paper, which is really putting the whole guidelines for this. But this is the story. The story of bariatric, in fact, started almost 100 years back. So when they noted that it does really, so any gastric surgery showed an effect on glucose metabolism. And this is a very famous family. They call them the obese family. And what they have done in this family basically is also gastric surgeries which have really improved them. But if you see the different stages until now, you could really recognize that there was a lot of reluctance to really use surgery in the management of metabolic diseases generally, not to say diabetic patients. And this guy is very well known to you, I'm sure. He has a very good story, and what he wrote, in fact, in that Nature paper, that he was really interested in seeing the effect, but unfortunately in the beginning he was not allowed to really recruit patients, that have made him try to do it in mouse, and you could see what has happened to this rat versus the other rats. So after then it was up until the 2006 and 2007 when this procedure have really been recognized as a very good way of managing diabetic patients. The same paper is showing you what happens when the patients are subjected to this bariatric surgery, and you can see after 5 years what has really has happened. Really great remission, but we have to be very careful here. The case selection here is really very meticulous. And you have to know that also you have to adopt certain things. I would like to also draw your attention to the basic metabolic changes when you compare surgical management with what we are now doing traditionally, which is the medical, dropping by almost 2% of hemoglobin A1C. Believe me, I'll show you in one of my slides, which is also from our data, it will reduce the complication rate very markedly. And this is what, in fact, should really drive or should be the force to drive the medical or the health system decision makers to really consider this type of surgery as a management tool. This is what we have. In fact, this is our inclusion and exclusion criteria. We recruited 312. We excluded 89 because of different reasons. One of them is just what has mentioned just a while ago, psychological problems or medical problems, or if they have a BMI less than 35. We use the cutoff of 35 because this is basically what is really being recommended. This is our inclusion criteria, which I don't think they are that much. Although sometimes we may exceed that age because of patients' pressure. They really, when we see someone who's 70, good 70s, and the patient is pushing, sometimes we take them. Those are the exclusion criteria. And what I'm going to present today is basically the outcome of 79 subjects who have really had a different type of bariatric surgeries. Those are waiting for surgery, and those are still in the investigatory process. So we are going to hit our target of 200 patients, hopefully, inshallah, by the end of this year. These are the different data. What I'm going to present to you today is only the clinical and the metabolic data of those patients. There are a lot of other markers. We have used all the incretins and insulin resistance, and also sometimes we calculated different rare hormones to see what happens to those hormones pre and post surgery. Now, our primary goal is to see the remission rate and the changes in the metabolic markers. And we concentrated only in this presentation, only in the weight, hemoglobin A1C, and blood glucose levels, and lipid profile, in addition to liver functions. We had 18 cases of bypass surgery, and we have 60 sleeve and 1 band. In fact, I included the band just because I thought you should know, although when you do any statistical analysis, I'm sure it will not really show any great significance. This is a very important curve because I would like to draw your attention from metabolic point of view that the first 6 months is the critical months for those patients. And this is what has happened to all our patients. If you see, we have 2 lines difference. So if you take the first 3 months, then you see that the rate of weight drop is about 3 kilograms per month, mainly subcutaneous fat, because we have the special machine which can assess both yellow and white fat, and we have seen that it was mainly the subcutaneous or white fat. There is more, this usually more in males, and usually with sleeve. While, interestingly, the sharp bar, which comes 3 months later, was at a rate of almost double rate, 6 kilograms per month, and usually visceral fat, and usually female, which makes sense, estrogen effect here, and also more with bypass surgery. So it seems that when you are really when you choose any surgery, you have to really keep in mind that those 3 months and the other consecutive 3 months are really critical, and you have to keep this in mind when you are really assessing your patients for any changes regarding his weight or even his metabolic phases. Now, this is what is happening with different with different patients and with different groups. Sorry, those are the sleeve, those are the bypass surgery, and this is the case which we did banding, and we have followed them up to 5 years now. So you could see very nice drop curve, but you can see also the band is not really doing a great job, although sleeve and bypass are really not that difficult, not that different. We are also interested to see how much the end point here. You could see how much drop basically in the BMI, not here where I'm talking about the BMI, and you can compare the three procedures. Now, when you look at the hemoglobin A1C, you could also see a drop, okay? And there is identical drop for both sleeve and bypass, although the band didn't change. And this could be explained, this very clearly explained, and we are going to put the data later on. In fact, when we finish the data, this is basically, you have to consider that the incretin is really hitting here very strongly, while we are really most likely losing them. But you have to also recognize that the weight have changed, and the insulin levels and the insulin resistance also is changing. This is how much drop of hemoglobin A1C in the first period, and you can see a very marked but non-significant difference for hemoglobin A1C drop. Now, if you see this box plot graph, and you see how much our patients have dropped from 9.7 to 7.4, then it's really a major drop. It's almost 2.2% of hemoglobin A1C. Now, if you want to use UKBDS data or DCCC study data, which tells you how much you can reduce the complication rate, if you drop by 1%, this is the end result. In fact, our patients will have less chance of developing neuropathy, 54%, retinopathy 34%, 29% nephropathy, and 26% vasculopathy. Believe me, I have been working on diabetes now for the last 30 or plus years. I don't think we have a drug which can do such a great job like what this is doing. Now, what I would like also to draw your attention to, that we thought, is it the insulin? Is it the insulin resistance? Is it the total body fat? Is it the value? So what we did here, in fact, we put a correlation between hemoglobin A1C changes and weight. And look at this. Look at the weight. The weight and the hemoglobin A1C are dropping smoothly identical until almost touching more than 6 months. And then later on, the weight will continue to drop, although the hemoglobin A1C start to slow. What does this mean? They have reached the phase of insulin resistance. They cannot improve anymore. Although they are losing weight, but they are not really improving. And unfortunately, I didn't put the figure. The figure here between those two values after 2 years is significant. What does this mean? This means that, yes, you may lose weight, but yet you cannot really overcome the insulin resistance. And this is why you got some people who are not going to be cured 100%. So those are the people who will remain type 2 diabetic patients, yet they have lost maybe a huge amount of weight. For that reason, I think. But in the first stages, in the earlier changes, I think they are almost identical. Now, this is just to show you what is happening with fasting blood sugar and 2 hours postprandial and different. You can see there is a very marked drop with sleeve versus gastric bypass. And the reason is for us, as an endocrinologist, is expected. The absorption is not going to be that affected. But in sleeve, the patients lose a lot of appetite because of a neural factor. And this is why their fasting blood sugar become really very markedly decreased. And also this is what is happening in the blood pressure. And this is how much reduction. But you have to keep in mind that part of it, that those people are already in antihypertensive medications, and they continue to be in also their hypertensive medications. Now, this is what is happening in the lipids, but I would like to maybe concentrate on this. Look at the changes in sleeve versus gastric bypass versus gastric banding, although you have to keep in mind that we have only one case here. Look at how much improvement you see in hemoglobin, in HDL, and how much drop in total cholesterol and also triglyceride. And also, there is a very good drop in LDL. Now, I have also to tell you that those people are already in anti-lipid medications, and this is what is happening after bariatric surgery and after even stopping the medications, which tells you that even if you stop the anti-lipid agents, still the patients improve from the surgery markedly. And I would love to see someone who will just go for 10 years and see and assess the mortality from cardiovascular disease on those people. This is what is happening with fatty liver, and you could see, and I'm sure you have seen it in many literature, what is happening with ALT, AST, and gamma GT, how much drop and how much improvement, in fact, with surgery. Now, this is what we have seen generally. This is how much drop in diabetes or remission. This is what is happening in hypertension. You would expect this. And also, this is what is happening with hyperuricemia. But I would like to draw your attention with the odds ratio that is really significant for diabetic patients and hyperuricemic, but not really much for hypertensive patients. Now, this also, when you are looking into the other markers, you could see that the significance is only seen with hemoglobin A1C and triglyceride and also HDL, but not much with total cholesterol. Now, how much oral agent we decrease? This is what is happening with metformin. You can decrease up to almost 60% of the, 40% of the dose. But the other oral agents, especially secretagogues, you could see we have decreased up to almost 1/4 of the total dose, if not stop hold the medications. And this is when the oral agents dropping, we are talking about 50%, insulin is almost 60%, and both even 20%, which is much better. This is the most important slide, and I'm sure this will trigger a lot of comments, I'm sure. The remission rate in our cohort, which is about almost 80, similar to my colleagues, is 67.3%. You may ask me why. I'll tell you why. Because we have chosen them from diabetic population who are really poorly controlled, and they are obese, and we reach nowhere. If this is what is happening, this is, believe me, better than any drugs, any magic drug we have as a diabetologist. Now, I want to also tell you that age, 6, baseline diabetes duration, which was also a question just now, values, and the change is really, does not signify or cannot tell us exactly who will have full remission and who will not have full remission. So there has to be some other factors which we have to really work out and maybe dig out to see why some people are not really improving. But because we started from 35 and above, I think if we start from 30, we would have even better outcome like what our colleague have just seen. I hope this will give you an idea of what has happened with our cohort metabolically and clinically, and I hope maybe next year we will show you some of the hormones and some of resistin and leptin effect of bariatrics on our diabetic population. Thank you very much.
Thank you, Dr. Alrubeaan. Now we invite for any question or any comment, please.
Thank you very much, Dr. Khalid. This is one of the best to speak we hear from endocrinologists.
Oh, thank you.
You have agreed that there was a consensus in IDDS meeting 2016 to consider bariatric surgery as a anti-diabetic procedure. But for us, the surgeon, this almost 40 years, we have observed the effect of different bariatric procedure on the weight loss and also on diabetes and other metabolic syndromes. I have noticed, it's a very nice study. I have noticed that you focused on the weight loss effect of this procedure, but we have another important factor here. We have anti-metabolic effect of this procedure, sleeve gastrectomy, RYGB, MGB, and also duodenal switch, and other malabsorptive. And I think the future for surgical procedure in the role of diabetes is promising. And we will see many of your colleagues in the future to be bariatrician, to study this procedure. And we hope that we can have an answer for many, many questions. Rubino himself, when he did the study in 2004 until 2007, he proved for everybody that the effect of GI bypass procedure on metabolic syndrome, sometimes even few days after the surgery, even before the weight loss comes in. So we have the gut hypothesis, we have the gut hypothesis, we have the imbalance between creatine, anti-incretin factors, many peptides, many hormones, many things that we still do not understand. Yeah. Definitely we need your help. Thank you very much.
Thank you very much. I would like to add that we are, in fact, in the process of even seeing how much we can save money when we do these surgeries. Imagine the people who refuse the surgery versus the people who have taken the surgery. We are saving thousands and thousands of money. I think this is part of our study, is to tell the government and also the insurance company that, look, if you do this surgery, you are going to save that much of money in the long run, and also you are going to prevent these complications. So yeah, I agree with you completely and with all your comments.
I have a few comments and questions. What the relation between BMI and resolution of diabetes? Did you mention any curve between BMI and resolution of diabetes?
Yes.
But I don't think it is not, I haven't noticed.
Yes, yes. No, there is a very nice correlation. Hemoglobin A1C drop.
No, BMI with
weight.
And resolution of diabetes.
No, we did not do the correlation.
You have the data, I think.
Yes, we have.
So you can do it. So
but here you have to be very careful. You have to prove that you have cured insulin resistance and that the insulin levels are normalizing and the other incretin is stable. And then you can say resolution of diabetes.
The curve should have three, hemoglobin 1C and BMI and resolution of diabetes. So we can follow the curve about insulin resistance and loss of weight. So it will be a nice curve.
You could.
Other thing, we are lucky that we have Dr. Khalid Alrubeaan. So our center and obesity center and excellence center in King Khalid, we are operating on his patient, but also we are accepting other patients from, that's why our resolution curve, he's managing difficult case, but we are lucky. We are managing some difficult and some easy cases. That's what our rate of resolution of diabetes is 80%. And this is 1 year, but he has 5 years. So I think we'll continue cooperation with our two center.
Thank you, Prof. Alrubeaan. I have two questions. The first question, do you think the remission rate would improve having the patient also in addition to surgery as such, having education, changing their behaviors, as well as dieting, you know? These are factors which are as important as surgery. So do you think that these were considered in your study?
Yes, it is. In fact, we have, you know, the patients, when he is selected from my clinic, number one, he go to psychologist, and he will be assessed by our psychologist. Then the social worker, then the educationist, then the nutritionist. And then if he is passed, we give them certain scoring system. If he passed all this, he will be now assessed for medically for the bariatric. We do all the workup which you need, and then we send the patient, and he will go. Either he will do it here or do it somewhere else. But eventually, this is what is happening. We never had any psych problems because we are very sensitive to this. But I agree with you. You cannot just do the case without full assessment and also education. But he also have education after. We teach him what will happen after sleeve. We teach him what will happen after bariatric surgery. Bypass surgery.
Excellent. Second question, did you encounter hypoglycemia and dumping after bariatric procedures, and how difficult they are to manage, and did you reach to a stage that you send them back to us to reverse surgery?
We have 3 patients with dumping syndrome, and we reconstruct 2. And one lady, she did her surgery in the United States. So our surgeon here was a little bit reluctant to take her without a full report of what has been done before. I think she's going back to do the surgery in the same center in the United States. Yes, we may reverse, but interestingly, the moment you reverse them, they go back to the diabetes clinic. Those patients who have full remission, they don't go back to our diabetes clinic. They are followed in our bariatric clinic.
Hypoglycemia?
Yes.
Did you counter hypoglycemia?
Yes, this is what I'm speaking about. Postprandial hypoglycemia, yes. But you have to know that
there is difference between dumping and hypoglycemia.
No, yeah, I mean, yeah, they have hypoglycemia secondary to a dumping syndrome, but also we have another causes of hypoglycemia sometimes with hyperplasia of beta cell and pancreatic changes. But this is very rare. We haven't seen, we have not proven a single case yet. That patient will have fasting hypoglycemia. Those people will have postprandial hypoglycemia, which is after meal.
One more question that really concerns us. Before we do bariatric procedure, do you recommend the glucose challenging test?
You don't need. No, you don't need, because here you are completely relying on hemoglobin A1C, which is far sensitive than oral glucose tolerance test. If you do oral glucose tolerance test after they normalize, they will have impaired, and we call them impaired fasting or impaired glucose. You are not going to really add any more information. The best marker for you here is basically how much hemoglobin A1C level you have, and you should bring it less than 6.5.
No, diabetic.
You are talking about diabetic, yeah.
Diabetic, yeah.
Diabetic will remain diabetic, and their impaired glucose tolerance will continue. Even if they have remission, you do oral glucose tolerance test, they still show you the abnormal curve.
Because the data show that those who has intolerance test positive, they are the people who would have hypoglycemia post-bariatric surgery.
I know now what you are talking about.
Yes.
No, sometimes we discover postprandial hypoglycemia by giving glucose load. Here we are not testing diabetes. Here we are testing postprandial hypoglycemia, the reflection after 3 hours. So what happens to those people, their insulin, their beta cell will secrete more than what is needed. So this is why they go and show blood sugar of about 2 or 1 even at 3 hours time.
So do you think that we should go?
You should, yeah. Whenever you are suspecting postprandial hypoglycemia, you should do what we call prolonged OGT. This is not to diagnose diabetes. This is just only to confirm that they have dropped their blood sugar level. Because you don't know, is it dumping syndrome, which is general symptoms and blood sugar is okay, or is it hypoglycemia? So you have to challenge them with 100 grams.
Yeah, that's what I'm asking, because you don't want to encounter patient having complications of bariatric surgery with dumping and hypoglycemia, having them known to have this after surgery by the glucose tolerance test.
Even if you diagnose them, there is treatment. We use acarbose. And we use also a high fiber diet, and this will minimize the postprandial hypoglycemia. Yes.
Work?
Sorry?
Do they work well?
Yes. I have some patients who are on acarbose and they are very happy with it. And they treatment, small meals and so on. But acarbose acarbose will prevent glucose absorption. So you lose this surge.
That's quite reassuring. Thank you very much.
Okay.
We're running out of time. Just only one question, please.
No, you cannot, because you don't know how much flow you are going to have in the gut.
Assalamu alaikum. Is it controlling the blood sugar and hemoglobin 1C will not show us the complication like peripheral vascular disease or diabetic foot? Because I have a patient who improved the hemoglobin 1C and still after 3 he presented with diabetic foot. So is it controlling the blood sugar as we see in hypertension? Hypertension does not affect us too much.
Yes.
Is it the other complication like the diabetic foot and
Yes.
the peripheral vascular disease controlled by this controlling of hemoglobin C or not?
Yeah, thank you very much. This is a fact which we have known for a long time now. You have to know that microvascular disease, which is retinopathy, nephropathy, and severe neuropathy, if you reach the phase 3, which is when the axon is lost, even if you do anything, you cannot reverse the disease. But if you have proliferative retinopathy and you control the patients, believe me, they regress. They normalize their retinopathy. And also nephropathy, the microalbuminuria may disappear. They may benefit from bariatric, but you have to catch them before they damage. They have structural damage.
I'm sorry, but for the do you recommend to do for BMI 30-35 sleeve gastrectomy? Because now we are limited to 35.
I was discussing with Hamid last week that yes, I do.
So we need referral from you.
There is a problem. I'll tell you why I cannot refer. We are controlled by the IRB. I have to take a permission.
I think in India and Asia they are doing for 35 because they have the approval for that.
Yeah.
But
30 even, yes.
Yeah, it's up to 30, yeah. But here in Saudi Arabia, 35. And usually...
We have...
Yeah, but you need to have a referral from dietitian.
Prof. Abdullah, I cannot refer because we are controlled by the IRB, and the IRB approval for us is 35 and above. We have, both of us, me and Hamid, have to write to them, telling them that we would like to bring our BMI to 30. Then I'll send the patients.
Yeah, thank you.
I think this is a hot subject, and we are running out of time.
Thank you very much.
Please, thank you, Dr. Alrubeaan. Thank you very much.